ACEP review. This is something that we've started this year, and this is our third session. Our first included FAST, then we did DVT, and this month we are doing cardiac. What we are focusing on is reviewing 2 articles. The schedule is, this is all Central Standard Time, so East Coast and West Coast, please accommodate the times accordingly, or adjust the times accordingly. But the first article will have a discussion and just a brief review of the article. Then what we'll do is we'll split up into small groups. We have a wonderful faculty that has agreed to assist us with being the small group proctors. We will divide everyone into small groups and we will discuss the second article. After that, we'll come back and we'll talk about some key points and some summary remarks from the second article. And then we'll be wrapping up at about 3 p.m. After that, if people are interested, again, this is not mandatory, but we have the second part of our series, which is the methods consults. This is especially for fellows or younger faculty, med students, residents that are interested in getting involved in research or would like to discuss their research proposals a little bit further. The panel of faculty will be on to answer any questions. And again, this is just a little bit less formal. It's just a nice discussion. So again, we ask that you please mute yourself, make sure you have your camera turned on, and then if you can, please change your name, write what position you are, if you're a student, a resident, a fellow, or a faculty member, and where you're located at. We love knowing where everyone's from. So the first article that we're going to discuss, we did all send these articles out, is going to be Bedside Focused Echo as a predictor of survival in cardiac arrest patients, and this is a systemic review. We have one of the wonderful authors, Dr. Paul Atkinson, that's going to be joining us here. He is joining us from north of the border. He is stationed in Canada. He is a professor of emergency medicine. He is the chair and the department head of emergency medicine, St. John's Regional Hospital. As well as the Assistant Dean of Research and the Deputy Editor of the Canadian Journal of Emergency Medicine. You can follow him, Twitter him at his Twitter handle, which is there on the screen for you if you have any further interest in that. So welcome, Dr. Atkinson. Thank you so much for joining us and taking time out of your busy day, as well as running your COVID unit, to have some time to discuss your article with us.
Well, thank you, Monika, and thanks everyone. It's a real pleasure to be here. This is an exciting event, and thanks for focusing in on this paper. I think we decided that probably one of the better ways to go through this was to be conversational. So I haven't actually prepared a PowerPoint on this. Hopefully everyone's had a chance to look at this paper. I might start off with a couple of remarks, though, Monika, if it's okay, just as to why I felt that we should initiate this work at that time. The paper's a little bit old now. It was published back in 2012 in Academic Emergency Medicine, but obviously the work was done even slightly before that. So I don't know about all of you, but back then, I guess 10 years ago, ultrasound, point of care ultrasound was certainly becoming standard of care, perhaps, in cardiac arrest. But there wasn't a lot of acceptance outside, perhaps, of emergency medicine, and certainly the ILCOR and other resuscitation bodies hadn't incorporated any advice about ultrasound into their guidelines. So I had just a personal encounter when I was back working. You might detect an accent, but I'm actually Irish, so don't hold that against me. But I was working in Cambridge in the UK at the time. And we had a case where a gentleman came in a code, was asystolic, was noted, we got him back to PEA. He was noted to have no cardiac contractility at all. And this was a young guy. He was, well, relatively young. He was in his 50s. He had no LV contraction on ultrasound at all, but we persisted because he was young. And in fact, we obtained return of spontaneous circulation. He was admitted to hospital and he walked out neurologically intact. And that kind of struck me as a little odd. And it didn't quite fit with what people were talking about at the time. And then when I moved to Canada in 2010, and I noticed that pretty much everyone was using ultrasound in codes and ending the codes if there was no contractility. And this kind of shocked me a little bit because I didn't think we were quite there in terms of evidence. So that was the clinical question that then inspired me to work with a student and lead this systematic review. It was a pretty basic systematic review. There wasn't a lot of literature at the time. We did it formally, though. We did it with a statistician, with a librarian, and somebody who's actually an international leader on systematic reviews, who's worked with Cochrane. And so I won't read it all out to you. You've probably looked at the paper, but I think what we found was that there were overall a small number of actual cases that have been reported out of probably the thousands of actual cases that had been practiced upon. So really, I'm not sure at that time, 10 years ago, if we had a good representative sample of actual practice. But what was there, we reported, we analyzed, and we found that, of course, ultrasound adds value. But I think our conclusion really was that it wasn't a standalone test. So it kind of pushed me, as with much of ultrasound, into a Bayesian framework, and that's how I tend to apply ultrasound in any area of practice. And I think this first systematic review for cardiac arrest ultrasound, I believe it was the first that was published, certainly back that up, that we have to be Bayesian, we have to have a pre-test probability, we have to relate the findings to the clinical situation. It's not a sort of gold standard tool that can be used in isolation. I know that's a very quick summary of the paper, but I do think that one of the things that and I'm sure you'll talk about limitations and things like that, we only looked at ROSC simply because at that time there really weren't the numbers published in the literature to look at anything beyond ROSC. There are now, of course, and there's been subsequent papers with the REASON studies, with our own shock papers, with further systematic reviews with Elizabeth Lalande from Quebec and Dr. Reynolds. And so there's been a couple more big systematic reviews more recently in the past 2 to 3 years. But I don't believe the conclusions have changed that much. I think we're still in this situation where, looking at the literature, there's strength certainly in repeated failure to see cardiac activity. And I think there's a nice study actually shows that the longer you go into a code, the more accurate POCUS becomes. And certainly at 10 minutes, you even approach 100% sensitivity specificity. But again, that study is pretty small, so it needs to be replicated. But I think that makes sense. I think REASON looked at the first ultrasound, but I often think that that's complex. The first ultrasound is sometimes immediately as somebody codes, it might be just after a shock. So you might have myocardial stunning. You haven't really had an opportunity to institute high quality CPR. So I think perhaps we need more nuanced studies that look at ultrasound throughout a code, and perhaps further analysis then to see when it might be at its most accurate. Again, this was very isolated. We just looked at the question of predicting outcomes, and specifically ROSC. And, the likelihood ratios here weren't super, a positive of 4.2, negative of 0.18. But those have improved, as I say, in later studies. But more importantly, I think if they're combined with other information, such as recent work that's looking at combining ultrasound with your ECG findings. So the combined finding of asystole on ECG and on ultrasound is much more accurate. And then combining at the other end of the spectrum, the PEA on ECG and finding motion on ultrasound together is a better positive predictor for a positive outcome. I'm not sure if there's a few other things I think probably in this literature that are worth mentioning. And One of those is the actual definitions. And we didn't really get into that in this paper, but I think it needs to be said that when reading these papers, there's often a lack of clarity around what do they mean by cardiac motion, right? So structured left ventricular contractility with wide opening of the mitral valve, clear wall motion, that's different than a flicker of the anterior mitral valve leaflet. And yet some of these studies included patients with just a flicker of the valve as cardiac motion. And I think that really is a major confounder in this literature. And I think a prospective study, another one, perhaps with more clear definitions. Now, Reason did, Dr. Gaspari's study did define cardiac motion, but I think it perhaps erred on the inclusive side slightly, and I'm an author in that, so I share in that. Perhaps we need to grade it and then look at the different strata as to how they behave as predictors. So that's another thought about this literature. You did ask me just to mention, how did this change practice for me? I think it made me reflect again on how to, as I mentioned, how to use ultrasound. And it actually prompted a group of us, including perhaps some on the call here, to look at a new protocol, which we call the SHOCK protocol, the sonography and hypotension and cardiac arrest protocol. And that's independent of the study, that infamous hated study that showed ultrasound didn't have any outcome benefits in hypotension. The cardiac arrest side of this, we did a modified Delphi study with international experts from North America, Europe, Australia, South Africa, and came up with, again, a Bayesian approach to this as to what to look for, how to look for it. And really, I think the value here is as much looking for reversible causes for tamponade, for underfilled patients, for a tension pneumothorax by adding lung ultrasound in, for maybe a massive PE, although that's difficult, with perhaps massive right ventricular dilatation and IVC distensions, but again, not always reliable. But to focus in on the possible cause maybe had more value than trying to predict the outcome. But we tried to incorporate that in again to this Bayesian approach, utilizing what pathologies are there, what information is useful, expert opinion, but also based on data that's published out there as to prevalence of pathology in peri-arrest and arrested patients. And again, we found that focusing in on the heart, the lungs, the IVC, and also adjuncts such as airway management and cardiac arrest might be a reasonable way. And we came up with the 5 Fs of looking for fluid, the form, which is the shape of the heart, the function, which is self-explanatory, and then filling and flow, which may involve, as I say, lung, IVC, and then adding some Doppler if in the peri-arrest setting. So I think that's really how this review of the literature helped me refocus in and how I use cardiac ultrasound in critically ill patients, was to build a layered Bayesian approach to what the questions are that I'm trying to answer. So, one other thing I've scribbled down here that I want to mention is that clearly a couple of years ago, there were 3 or 4 papers came out cautioning us about using point-of-care ultrasound in cardiac arrest because of the potential pauses in CPR, and that's real. And a lot of the literature, in fact, some unpublished work that I'm privy to, does show that even in a mock setting, we tend to take more than 10 seconds to get the views. Now, it's possible. In fact, we have an early paper that one of the ones in this, that when I was in Cambridge, Hayhurst, we looked at this and found that you can actually get a scan in 85% of the time in an actual code. Other papers have shown perhaps delays of up to 20 seconds in one paper, 16 in another. So these are not short delays. So we got to be careful that we're not doing harm when we haven't actually shown any proof of benefit yet, certainly either in terms of very accurate prediction of outcome or actually changing that outcome. So I think that's important, and it probably leads down to the discussion of using transesophageal echo in this setting as opposed to transthoracic. That's a whole other topic. I do think one of the other bits of cool research that's going on are some animal studies that are looking at using ultrasound, possibly even a bladder scanner, for lay people to identify where the heart is to help guide positioning of hands for CPR. So that might be something that again spins out of this interest in cardiac arrest ultrasound. But that's not ready for prime time yet. It's still in animal studies at the moment. So I guess I would summarize all of that up by saying, look, there's no perfect test to predict outcome in cardiac arrest, but I do think ultrasound has utility. Approach it in a Bayesian way. I think using the likelihood ratios as opposed to an absolute sensitivity specificity helps us think about it better. Having an approach that looks maybe beyond the heart as well at times to minimize pauses in CPR. And I think also we probably need an RCT. I think there's enough people practicing now that without, I mean, it maybe would have to be some form of staged RCT, a bit like the Jones original one in hypotension, where you wouldn't want to eliminate POCUS completely, but you might have an immediate versus delayed. Again, there would be those sort of standard of care and ethical considerations, but I don't know that we've proven it saves lives. So I think there is certainly a question to be answered at this point. Hopefully that's a reasonable summary of my thoughts, but happy to engage in questions.
Great, thank you so much for that review of the article. Just a quick question I have, and especially for our younger faculty or fellows, what have you found that is the best way for them to get involved in research, especially if they're coming from a less academic center or they don't have a good place to start? Do you have any recommendations or tips that now looking back on your research career that you would like to share with them?
Sure. No, that's a great question. I think you have to have a question that you want to answer personally. That's important, right? I think research is hard. It's going to take over your evenings and your weekends. You need to believe that it's worth it. So pose a question. Pose more than one question. Collaborate. Don't try to do it by yourself. I don't believe I have any papers where I'm just the sole author. I think it's a recipe for disaster. Find someone else who's published in the area, someone else who's interested in the area. Collaborate with them and learn. I think starting with either some observational data, we all scan and we can all keep records of our scans. And if we're in a group, it doesn't have to be an academic group. We can set up small data sets but think of an interesting question that someone hasn't answered already and see if you can have enough data to look at that, even if it's just a small local study. But better than that, I think most of us have networks. Everyone on this call has a network. This is a network. Reach out through the network you're involved in and see who else is interested in your question, and then have 10 data sets from different places and bring them together. And don't be put off by the red tape. You know, universities are there to help. I think it's important just to explain what you're trying to do and make sure that they know that it's safe, ethical, and that there's a purpose. And then they'll usually turn around and actually help you. Systematic review is a reasonable way to get started. So I mentioned observational data because quality data, that's good, but systematic reviews are very reasonable, especially if you can find a group of studies that are out there, but there hasn't been a review. So no one's tied it all together yet. Then I think that's a great way to start. And if you are going to do that, speak to your hospital or university librarian, because they can really help talk you through it, walk you through it, and get you to the finish line on that.
Great, thank you so much for that advice. I wanted to open up the floor to any of our faculty or fellows or residents if they specifically have any questions for Dr. Atkinson in regarding to this article.
I'll just ask a question. This is Lynn Rapolo. Hi, I'm from UT Southwestern. Thank you so much for that presentation. I love going over an article when you actually have the actual author there. So you mentioned you had, and so I've been doing just random research projects for many years. And one of the things that I find that is incredibly helpful is to get your statistician involved. And in planning and preparation and your research, once you actually plan it, and even doing a pilot is also incredibly helpful, because the worst case scenario, I shouldn't say the worst case scenario, but to do all this work and then to submit it for publication, which is, what you want. If you didn't publish it, it didn't happen, sort of thing, as far as universities are concerned. But to have feedback about your methodology and it's just not publishable, or they'll say, well, why don't you redo the study and do this? You know what I mean? So if you network and you just, because there's just so much to know about research and so much to know about medicine, and most emergency physicians, most physicians in general, aren't savvy at research methodology. And so I really like the idea of getting a statistician involved and just doing a lot of preparation, finding ideas actually from other studies and seeing what their faults were, looking at the limitations. And then when you actually do the study, you did so much planning that your actual data collection is just putting in the numbers. Your paper should already be written, is the ideal way to do it. Can you just talk about your statistician, and because doing a systematic review is a lot of work, but it's but very interesting, because you're collecting knowledge from good research and kind of compiling it for people like us, and so we can benefit from all of your work. If you can just kind of talk about how you approach doing the systematic review.
Well, for sure. And what I'm not going to try to do, because we don't have the time here, is to really get into too much of the detail of the actual methods. But to your point of involving a statistician, I think some of the things that you got to really be wary about in a systematic review is the decision as to whether you're going to do a meta-analysis or not, because there's no firm conclusion, and there are variable opinions as to what level of heterogeneity one should say, no, we're not going to combine this data set, we're just going to report on the individual studies and look for themes. We made the decision that we would do a meta-analysis. Some have argued, when I presented this at ACEP, some argued that the heterogeneity was a little bit too high. And what I mean by that is, for anyone who's not sure of that term, is that there may be too many differences within a particular outcome across the studies. So that sort of heterogeneity around results. There's obviously clearly potential for variability in terms of the setting, patient selection, all of that. And so that's why you do some sort of quality review of the articles. And we used a modified QuadAS score for this and went through each one and excluded 4 papers, if I remember correctly, just because we didn't feel they were methodologically sound. So I think having somebody to do that with you, so that you're not just doing that as a clinician, you can ask the clinical question for sure. You can say, well, I don't think they answered this clearly. But I think having somebody with, and it doesn't always have to be a PhD level statistician, it can be somebody with experience, it can be master's level, it can be somebody who just focuses on systematic review and meta-analysis methodology as part of their academic interest. But as long as somebody understands how you do that quality review, how you do some measures of heterogeneity, and how you pull your data, whether you use sort of fixed or random effects, which again all depends on the variability of the type of studies you're looking at. So these are questions that maybe when starting out you might not know how to answer, but for a statistician these are bread and butter. And that's why I would agree with you, Lynn, you must get in early and ask these key questions. And I also think, I hate to say this, but I believe as emergency physicians, we are very good at shortcuts. And I think there's no harm in balancing this whole very formal systematic review with what you would do if you were sitting in the department and you needed to answer a question, which is probably quickly get onto Google Scholar or get onto Trip Database or one of those and And so that's, I will admit that when we say here, we searched the gray literature and we did manual reference reviews, we also, go onto Google. We also go into Google Scholar. We also ask around people, call up some people that who have published in the area, and get them to check your list in case you miss something big, because that happens. PubMed doesn't catch everything unless you get the mesh terms perfect. So I think just being careful, as you say, Lynn, at the beginning, get your structure set up, and then it all flows from there reasonably easily after that. And probably don't over rely on a meta-analysis, right? You got to have a little bit of skepticism about the numbers. Don't just accept what it spits out, because if the studies are poor, combining them into 10 poor studies isn't going to give you one great answer. So
Some people, evidence-based medicine is the research, your experience, and kind of your clinical scenario that is in front of you.
Mm-hmm.
And I do want to mention that one thing, we did a study, we looked at a database of cardiac arrest and looked at the actual strips and measured how long that pauses before there is that stunning that happens after you defibrillate people. And it was over 120 seconds in 25% of the patients that we studied. And this was a database study, so it was all like retrospective stuff. But
I think that's super important, and I think that really plays into this. And I wonder whether or not we do actually need to think carefully again about where ultrasound should fit into our cardiac arrest algorithm. But in the same way that we don't do a pulse check right now, right after shocking, we carry on CPR. I think it makes sense, right, to wait a minute at least. But as you're saying, sometimes that minute may not be long enough.
Yeah. So after the defibrillation, you don't check a pulse. You actually do a cycle for 2 minutes, and that's kind of a study that we did that supported the ACLS guidelines for it.
For sure. No, you're right.
Yeah.
Although I have to admit, with the TEE, people do look right while before that time comes out, bad habits kick in.
It's all good. I think it's helpful, definitely, but you have to use it in the clinical context.
For sure.
Great. Thank you again, Dr. Atkinson, for taking the time to discuss your research with us, as well as the tips and answering some of our questions.